Great. Well, thank you, and welcome everybody to the Huntsman Cancer Institute Regional Symposium of the ACPMP Research Symposium. Thank Deb Shelton, who's here with us, and thank you for hosting this event again, and also to Nikki, Dr. Nikki Leonard, who is one of our pathologists here, who graciously participated in our mock tumor board earlier and has been available to answer questions. And we welcome Dr. Erin Ward, who's one of our surgical oncologists here, who just joined us. And this is really one of my most favorite parts of the symposium. It's a little bit smaller. It's a little bit easier to interact with the participants. And also, I think this part really brings home the whole reason for the existence for the ACPMP Research Foundation, brings home the whole reason for Dr. Ward and I doing what we do, and for Dr. Leonard as well. And that's really to help people who have appendiceal cancer and their families, helping them navigate this incredibly challenging disease that has an incredibly challenging treatment options and a lot of unknowns. But as we heard earlier today, with a lot going forward and a lot of research being done, and there's a lot of hope on the horizon. And so one of the things that we've always done as part of our regional aspect of the symposium is to invite a patient and their family to share some of their journey, because I think a huge part of the symposium is to let people know that they're not alone in this, that their journey, while each journey is individual, parts of it may not be unique. And I think there's comfort in knowing that other people have traveled this path as well, and successfully, and can share some of the ups and downs, and maybe some advice about navigating through these difficult waters and times. So today I've invited Laurie and John Rutledge to share their story. We've known each other for quite a long time now, a number of years, and it's been my privilege to be a part of their team and taking care of Laurie and John. And I'm going to let them share what they want to share about their experience with all of this. So Laurie and John, thank you so much for joining us, and please, the microphone is yours.
Thank you, Dr. Lambert. Our journey, and I definitely mean our journey, began in August of 2015. I was visiting our son and his family back in Minnesota, and I remember so well going on walks with them and their new baby. And as I would push the stroller, I had this strange sensation in my abdomen every time we would start to go up a hill. This happened each time that we went for a walk and I pushed the stroller up the hill. And I thought to myself, oh, I must be gaining some weight when I get home. I need to do something about that. Well, I got home and life seemed great, and until I noticed that my abdomen was starting to grow. It was growing as if I was pregnant, but I knew I wasn't. I was way too old for that. So I made an appointment with my GP doctor, and he ordered some scans, which showed that I had a mass in my abdomen. He assumed it was probably a tumor on an ovary. And so he arranged for me to go see a gynecologic oncologist down in Salt Lake City who did more scans, and she agreed with my GP doctor. By then, my abdomen looked like I was 9 months pregnant. We would tease with my youngest son and say, if you want to know how your mom looked pregnant, because he never, of course, got to see that, look at her now. This is how she looked just before you were born. And I never seemed to really worry about any of it for some reason. I didn't have any other symptoms. I felt fine. But we went down and we had this surgery in Salt Lake City. and I found out when I woke up that I had had a complete hysterectomy and that I had a tumor on my appendix, not on my ovary. So they had removed my appendix and the tumor. But the bad news was that the tumor had burst before they were able to get to it and to remove it. So not knowing what this was all about, this oncologist sent me up to the Huntsman Cancer Institute. And I was later diagnosed with PNP. In the spring of 2018, my CT scan, I had been having scans up till then, but this one particular one showed that I needed to have some surgery once again. So we didn't know where we could go for this surgery or anything.
We had been told that we would have to go out of state to the Mayo or some of the other hospitals that did heated chemo, and we mentioned that to the doctor that we were going to have to go out of town, out of state,
and found out that a new doctor had just joined the Huntsman Cancer Institute, and that was Dr. Laura Lambert. She was a specialist in PNP and HIPIC. We were so excited that she was here. We weren't going to have to go away. We met with Dr. Lambert in late June of that year, 2015, and she explained to us the surgery and the procedures that she would be doing. Cytoreductive surgery with hypothermic, trying to get all these words right, intraperitoneal chemoperfusion, or CRS/HIPIC. Even though she explained it so well, I was still scared right to death. We did some reading on this subject and we found out that this surgery was called the MOS or MOS, which stood for the mother of all surgeries. I had my first CRS/HIPIC the end of June in 2018. I couldn't believe a surgery could go so long. I don't remember exactly, but it seems like it was over 12-hour surgery. And I was beat by the time I got out of that. I remember it being a hard road. John was with me every moment. He stayed at the hospital with me. And I think we were there about 10 days before we were cleared to go home. We had been told it was going to be a hard recovery. I don't think we had any idea how hard. It was long. I'm not going to sugarcoat that. We had been warned, and it really was a hard recovery. That my sweet husband, he took such great care of me. He stepped up as my nurse, my caregiver, my meal maker. He did the laundry. He was the housekeeper. I think he learned a lot of things that he never knew how to do before that. I could absolutely never have gotten through this surgery and the recovery without him. I don't think it would be possible to go through CRS and HIPIC and the recovery without a good partner, family member, or a friend by your side. If I could give any advice on recovering from the CRS HIPICs, it would be to follow your doctor's orders and advice. Don't get discouraged with how slow your recovery is going, because it is slow. Just keep pushing through and being excited about every new little thing that you accomplish each day. I remember sitting on a shower chair in the shower with John by my side and thinking, I'm never going to get through this. I can't even bathe myself. I'm not strong enough to get up. I'm not going to do it. But we kept pushing. The walks were hard to begin with. I remember my sister, who lives next door, volunteering to walk with me. And at first we would just walk a few steps. After a couple or 3 days, we were able to go a block and then a little bit farther. So recovery came, but it was very slow. After I recovered, I started chemotherapy. About all good I can say about that. is that I met a lot of wonderful people going through this same hellish experience that we were going through.
They become friends, and then after a little while, they become family.
Again, my dear husband was there by my side through each of these sessions. He got to know all of the nurses and the other patients just as well as I did. He loved visiting with all of them. They tried many different types of chemo. Some of them would work to begin with, and then they would all quit working, each one failing in the end. We went back to the Mayo Clinic in Rochester, Minnesota, because that's where our son works. And we saw a couple of oncologists there. And both of them said to me, "Why are you doing chemotherapy? It's not going to help you in your situation. You just need to go home and enjoy more of a better quality of life than you would have if you continued on with the chemotherapy." So we came home, we consulted with Dr. Lambert, and she agreed that we should probably stop the chemo. I have to look at my notes so I can remember. After that, I had CT scans every 3 months until I started feeling crummy in the fall of 2020. My CT scan then showed the cancer was active again. Dr. Lambert agreed to do the CRS HiPic on me once again. 2 weeks before Christmas of 2020, I had surgery once again. I went through the surgery, the hospital stay, and the long recovery all over. This time we knew what we were in for, so it wasn't quite as hard.
No, it was easier.
Because we knew what had to be done and where we were headed and everything, and we made it through together. Since then, I've had CT scans every 3 months. I felt really good. After a scan that shows no real progress or expanding of the cancer mucins, I would sigh a big sigh of relief. I could breathe again, and I could try to live a normal life for a while. I still get tired easily, and the neuropathy in my feet and hands from the chemotherapy is my main problem. I take medication for that every day. But then the next scan gets closer and closer, and I start to get nervous and worry again. Will this be the scan that shows the sleeping giant inside of me is awakening? What could this bring to our lives again? Next week is my scan again. The worry has set back in, but I'm trying to be positive.
Laurie can do whatever she wants to do because she likes to garden, she likes to be outside, and that keeps her busy, keeps her mind off things. But she can do pretty much whatever she wants to do. It hasn't, after she's recovered, it hasn't slowed her down any.
And I know that without a major miracle, I'll live with this for the rest of my life. This part gets hard, but without the heroes in my life, I wouldn't be where I am today. Dr. Lambert, you're truly an angel in doctor's clothes. I owe my life to you more than once. I can never, ever thank you enough for all that you have done for me. Thank you. And John, my sweet husband, and my caregiver, I don't even know what to say. I love him so much. I can only imagine what caregivers in our lives are going through mentally. The fears that they don't want us to know, that they don't want to talk about. They're also angels that are sent to help us along this road that we never asked to go down, and they walk right beside us. In conclusion, I just want to thank all of the researchers doing all they can to try and find a cure, the doctors, the hospitals, the families, and the caregivers that are doing all they can to help us fight and hopefully overcome PMP. Thank you.
Thank you, Laurie. John, do you want to add anything from
It's just, it's hard as a caregiver. I mean, it's not easy, but you you'll get through it. You just have to have a lot of patience, a lot of kind of the understanding what's happening, and they, after the operation and they go home, they can't get up, they can't without help, and it's hard, but it gets easier, as time goes on, and Laurie's had 3 operations, and we kind of know each one of them what's happening, and it gets a little bit easier, but it's still, you have to have a lot of patience.
Yeah. Yes. I think I say that to everybody that we do HIPEC on, that this is going to be a lesson in patience, right? You feel like you should be getting better more quickly, and maybe you've had a surgery before and you've recovered so much quicker. And I hear that a lot from people. I recover really quickly from surgery, and I'm like, I know, and I'm sure you do. But when you add chemotherapy to it, it really does change the recovery and the amount of time that it takes. And you just have to measure those steps. They're small, but you just have to keep counting as you go forward. But I asked you two in particular for a number of reasons. One, because your journey has been so remarkable, and you have gone through it together, and I know the support that you've provided each other, and how difficult it's been. And Lori actually left out a number of additional hurdles that she came over, that you both came over.
I didn't want to scare
process, which is fine. But one of the things, about your story also that I, that made me think of you for this is because a lot of what we discussed today in the symposium was about how the biology, what's going on within the tumor, is what ends up driving the outcomes, more so than what Dr. Leonard and her colleagues can see under the microscope, and more so than what Dr. Ward and I can see at the time of surgery, and can understand from at that time. And one of the things, now we're getting into the medical stuff, but that's interesting about the way your tumor behaved was that when, Dr. Leonard and her colleagues looked at it under the microscope, it was looked at, it's one of these low-grade mucinous neoplasms of the appendix, and the PMP was grade 1. It has always been grade 1, which to Dr. Ward and I and other surgical oncologists, we feel very confident that surgery is going to be helpful, and that it should be very effective. And we did not get the response from the surgery with the HIPEC that we wanted for you. It just did not. Like, I was shocked. I think it was less than a year after your surgery, which I thought was a good surgery, and the cancer was back. And so in my mind, that raises the question, was it not read correctly by the pathologist, or was there something that we missed, or is there something else going on? So we went back to the tumor board and asked the pathologist to re-review it and just say, hey, this is behaving more like a true cancer than this low-grade neoplasm and pseudomyxoma. And they went back over the slides, and sure enough, we saw them in the tumor board. No, it really looked like this grade 1 PMP. And I guess either Dr. Leonard or Dr. Ward, what are your thoughts about that? I mean, I guess I don't. Maybe Dr. Leonard, from your perspective as a pathologist, what are the challenges that you face when you're, you get these tumors, like you mentioned earlier, you get these buckets of tumors and or mucin and large tumor specimens, and the appendix certainly looks one way, but when we come back and we say, look, we're seeing this discordant behavior. What are the thoughts from the pathologist? What are you thinking? What are the questions that come to your mind about that?
I think, like you mentioned, it's we're always wondering, was there something left in the bucket that we should have seen? But there's no way, like I mentioned before, we just physically can't submit all the tissue that we get. So there is always the possibility. But then, like you said, with your surgical impression in this case, like it also was surprising to you that it came back just like how things look to you. So it can be really challenging. I think in our field, interpreting the slides is even difficult because a lot of the papers and the guidelines that we go off of are based on sometimes not a lot of cases with not a lot of good outcome data. So it can be hard for us to correlate exactly what we're seeing with what to expect. One of the problems is that the terminology is kind of inconsistent. It's been changing over time, and people who are not as experienced might call these tumors slightly different names. And then when we're trying to do research, we can't really identify the cases that we should be looking at to do the research. And then we also don't know for sure if they sampled well, if they properly diagnosed the cancer or the low grade tumor at that time. So I think a lot of the data that we go off of for diagnosis and prognosis is potentially not the highest quality just because of those challenges with this kind of disease.
Mm-hmm. Yeah. And Dr. Ward, I know we're looking at better ways of predicting behavior. What are your thoughts? When this happens, we think the tumor is going to behave a certain way, and then it doesn't. Your thoughts about how to handle that and what we're looking at here?
Yeah, I mean, I think the most frustrating part of this whole process is that we want to be able to tell patients how we think they're going to do with confidence. And I think these experiences kind of undermine some of that confidence, even when we have the best people, right? Knowing that Dr. Lambert had a really good surgery, knowing the people at University of Utah pathologists are incredibly skilled and well-versed in this disease, and still having that variation is frustrating for the practitioners, but I'm sure incredibly frustrating for patients. Mm-hmm. And that's hard to, not have the same confidence. But I think, the same way I think of CT scans is we're only as good as our current technology, right? So I think we're asking pathologists to pick up on things they can't see under a microscope. And I think it was really exciting to hear about all the people who are pursuing genomic research to figure out if mutations can really help us figure out which patients, really help prognosticate in a way that pathology may not be able to help us. And maybe ultimately will help Dr. Leonard and other pathologists do better research, comparing, tumors with certain mutations and lining those up with what they see under the microscope. So one of the studies we recently got some funding for is to correlate specifically for these patients with low-grade mucinous neoplasms or low-grade adenocarcinomas, figure out if we can identify mutational patterns that correlate with prognosis, how patients do, but also what we find in the operating room, which I think Dr. Lambert and I talk a lot about. We can have the same pathologic diagnosis from biopsies, and then we go into the operating room and find very different appearing disease. I think you mentioned it earlier. The lame term would be, I think stickiness is a great way to describe it. How adherent is that disease to the tissue? And my hope is, that we can really kind of take everything that we're actively working on and bring it together. So, send patients tumors, get mutations, figure out if that correlates with what Dr. Leonard sees under the microscope, and then also what Dr. Lambert and I see in the operating room. And I'm hoping that's, maybe some window into a better way to prognosticate or help patients figure out how likely is this to come back.
Yeah. So just like a lot of the studies that we heard today, where these molecular subtypes are predicting survival, but also like risk behavior, response to chemotherapy. one of the things that Dr. Ward and I are hoping to identify is if these molecular subtypes can also predict the ability to get a good cytoreduction, right? So that stickiness that she was talking about, as we discussed earlier, when we look at a CT scan, we have a sense of, where the tumor is, how much there is. Some of it's mucin, some of it's more solid, and we have an idea that we can get it out based on our previous experience. But ultimately, it's when you get in and you find out how stuck to it is to things and how many things it's stuck to. So there's two elements, how much is there, what is it stuck to, and then how stuck is it to the things that it is stuck to, that drive our decision making at the time of surgery. And so, it can be very, as somebody mentioned earlier today, a case where it was disappointing to have to come out and say to somebody that we can't get the tumor, all of the tumor out. And that's hard to hear. And so those are the things that we're working on here as well. And, some other aspects of Lori's situation that are also very common that people hear, right? So getting diagnosed as a woman, getting diagnosed with an ovarian cancer first, and getting sent first to a gynecologist or a gynecologic oncologist. And she was lucky that the person picked up that this was not coming from the ovary early and recognized that it was coming from the appendix, because oftentimes what we'll see is women who get referred to a gynecologic oncologist, and they'll get major surgery for ovarian cancer, and sometimes even get started on chemotherapy for ovarian cancer that's not going to be as effective as well, it's not going to be effective at all. And unfortunately, some women get treated with ovarian type of chemotherapy for a long period of time before somebody realizes it's not responding the way it's supposed to, and then recognize what should be happening. But the reason why Lori ended up on, you heard a lot of conversation today about chemotherapy not being effective for low-grade mucinous neoplasms, but there are times when, just because it looks one way under the microscope, if it's not behaving the way we think it should, just based on the way it looks under the microscope, we have to then start thinking, okay, what's the next step? And so a number of the questions that came up earlier were about next steps if the cancer does recur. And, one of the things that we talked about was doing another surgery at that time. So Dr. Ward, what are your thoughts about, how do you think about timing of surgery for recurrences? What are your thoughts about that?
I mean, I think, we always think about how quickly something comes back. So if disease comes back very quickly, it makes me wonder if even really good surgery is going to be effective immediately. And it also would make me go back to the drawing board, just like you guys did, and ask for a review of the pathology again, or, try to figure out if we're missing something that may have suggested that other systemic therapy, other therapies like chemo might be helpful. I think, traditionally for low-grade appendiceal mucinous neoplasms, especially if there's a long time period between recurrences, I think it's still probably our best bet, but it's still a hard thing to recover from. And sometimes it's still very hard to get a complete cytoreduction when it's a second time around. So we just have to be thoughtful about, again, reassessing this, how much disease and how stuck it is and what it's stuck to, and always reconsidering if we have the right diagnosis. Yeah,
exactly. Yeah. And so the things that I think about are the same too, is how quickly did it come back? Where did it come back? If there's data to show that when it comes back more than what the person had at the first surgery, you're very unlikely to get a complete tumor removal like you mentioned, Dr. Ward. So all that factors in. And in Lori's case, it came back way quicker than any of us wanted or expected. And so we went based on how the tumor was behaving rather than what we were seeing. And that's why we recommended chemotherapy, which she did do for a very long time. And you know, it's hard to say whether it helped or not, right? I mean, the tumor came back quickly, and then we controlled it. It was controlled by the chemotherapy for a long time. And I do think it was effective. And you also had some immunotherapy as well, right?
Mm-hmm.
Yeah. So we were really thinking, you know, thinking outside the box and really trying to treat this. And you know, she went through all these treatments, and then ultimately we did decide it was probably reasonable to stop the therapy, and then we decided to do another surgery. Right. And we weren't really sure what we were going to get into at that time. Thankfully it was helpful. If I remember correctly, you were having quite a lot of symptoms at that time, and we just figured, you know, we were starting to have trouble eating, and we were losing weight and energy, and we just figured out we needed to do something, and surgery seemed like an option. Although we were cautiously optimistic about the goals that we were talking about, right? We were going to see what we could do. And unfortunately, it seemed to pay off. Would you agree?
Yes,
yeah,
I'm still here.
Yeah. Yeah, so that worked well. And now we're in the surveillance, and I think you eloquently described how challenging that is, waiting for that next CT scan, and you know, the anxiety that comes around that. Maybe can you guys speak to a little bit are things that you do to try to alleviate that? How do you handle as you're approaching these different scans?
Well, first off, we don't talk about it. We know it's coming up, but we don't talk about it. And then it's to keep her busy, to keep things going where she doesn't have time to think about it.
Yeah.
And I don't mean to throw religion into it, but we tell all of our kids, you know, their grandchildren, Grandma and Mom's got another scan. Please pray for her. And so far it's worked.
Yeah. That's great. So Dr. Ward, do you want to talk a little bit more about the cell-free DNA? That was another topic that came up, about the role of checking for cell-free DNA.
Yeah.
In these tumors.
Yeah, I think, you know, there's been a couple groups, including Dr. Taraga's group, have done a nice job of showing that with the higher grade, like the appendiceal adenocarcinomas, the ones that are more traditionally called cancers, circulating tumor DNA, which is where they take a sample of your blood and look for specific mutations that they found in the tissue of your tumor. And they can say whether or not they're circulating tumor, like in your bloodstream, tumor DNA. Dr. Taraga found that for patients with either colon cancer, peritoneal disease, or appendiceal adenocarcinoma peritoneal disease, that it can give you a heads up that you might have a recurrence a couple months ahead of time. There has not been a lot of great data showing that's effective for tumors that aren't as rapidly growing, like low-grade appendiceal mucinous neoplasms or low-grade PMP. But I think this goes to the point that we don't really know how to really categorize those patients who have, you know, low-grade PMP that acts more like aggressive cancer. So our hope is to, you know, gather samples for patients who have these low-grade, you know, tumors that maybe are acting more high grade, and seeing if those patients would benefit from being followed with circulating tumor DNA tests. So in addition to, you know, traditional tumor markers as well as imaging, because it may be that it's not just the high grade tumor or patients with high grade tumors that would benefit from being followed, but maybe those patients, like, you know, Lori's tumor that acted like it was a little bit higher grade, maybe there would be benefit for you from following with circulating tumor DNA. But right now we don't know, because there hasn't been any correlation with genomic testing and ctDNA that we're aware of. So that's one of the things we're doing as well.
Right. You could imagine if we, we're testing everybody with cell-free DNA, even people with low-grade tumors, and if somebody had had cell-free DNA after their surgery, we might think about, if we can correlate that with behavior, then we might start chemotherapy right away after surgery and not wait for a recurrence before we do something to see if we could have an impact on the disease, survival and stuff. So lots of things going on. I hope that came through from the symposium. There's a lot of really good research. I was really excited this year about all the additional input from medical oncologists that we had, Dr. Shen and Dr. Foote. Really exciting. The Q&A was blowing up with questions for both of them, which was great. And because that we really do need to start figuring out more ways of treating the cancer, especially if it comes back, and identifying people who will benefit from systemic chemotherapy. I would love to open this up to if there's any questions from the participants. Please feel free to put them in the Q&A, and we'll be happy to try to answer any questions that you have, either for Dr. Leonard from pathology, Dr. Warderai from surgical oncology. We can try to field some medical oncology questions, or for Lori and John about the patient experience. Deborah, do you have any questions left over from the main symposium that you can think of that we could try?
Yeah, I mean, I just, first of all, I just really appreciate this session. And Laurie and John, I really appreciate you sharing your story and experience. Very briefly, I'm a caregiver to Sarah's HIPAC patient that was diagnosed with PMP in 2018. And so I was just really so moved and so touched by your story, especially, now I'm going to get choked up again, sorry, but especially about how the two of you clearly are just so in love and just work like a machine together, just, and I just really think that's exactly what it takes, because it is hard. And I've been fortunate to I think my spouse would say I'm a good caregiver. You were so generous, Laurie, with your praise. I don't think I was close to as good as John, but hopefully, I scratch the itch there. But so I just really want to just thank you both. I don't think we hit so many questions, Dr. Lambert. You all did a fantastic job, especially you, really banging out a lot of the answers. One question that does come up when I talk to other patients and caregivers, and that I kind of have myself, is this kind of, when you're talking about what the pathology comes back with, but then the disease seems to behave differently, there's that discordance. Could that be driven by what they call, like, when they do pathology after CRS HIPAC, and those so-called focal areas of high-grade disease, but it's always like focal area? Is that kind of what we're talking about when we say, well, we can't always see everything that's in the bucket because there's so much in the bucket, Dr. Leonard? Is it just that there's so much to look at that there may be little places where the cells are behaving differently, but they end up driving things?
Yeah, it's definitely possible. Like we can't look at the tissue just with our eyes and say, okay, that part is definitely high grade and this part's definitely low grade. Sometimes we can have hints. And then sometimes, like you said, with the focal cells, it's probably frustrating to read reports that say focal atypical cells possibly representative of tumor, which sometimes we have to say just because our technology is just limited. by the nature of, like, once you give chemotherapy to tumors, especially, they change how they look, and they change what kinds of molecules they express. So sometimes we can't even prove that it's a tumor cell, or if it's just chemotherapy. Radiation too, not as applicable here, but can change the way your normal cells look too. So sometimes we can't tell if it's just a normal cell that has a funny look because of the treatment, or if it's a cancer cell. So those are some of the reasons why we can't always be sure. And then sometimes we might not, if we're not sure, and we might say there's no tumor here that we can prove, then it could come back because maybe it was tumor and we just are limited in our assessment.
Right. And I see some questions have come through. Thank you, Dr. Leonard.
Yeah.
Take it away, Dr. Lambert.
All right. So here's a question, Dr. Ward. I don't know if you have any information on this. The question is about BRAF mutations and their prognostication in appendiceal cancer. We know they're not good in colon cancer. Are you aware of any data specifically looking at BRAF mutations in appendix cancer?
I am not aware of any specific large series that would be able to answer that question. Like you mentioned, both in melanoma and colon, it's not always a great prognosis. But that being said, there are some specific treatments that can target BRAF mutations. So sometimes, you know, it's a catch-22. We have something else we can offer you that may be able to specifically target your tumor, which is sometimes wonderful. You know, I think as we do more and more large studies looking at the genomic profile, we will find out if BRAF mutations have the same implications for appendix, but I'm not aware of any large series that I could feel confident answering that.
Yeah, I agree. Obviously, you know, BRAF mutations in colon cancer don't have a good reputation, but you know, we've heard over and over, multiple years now, and again, more publications this year, that colon cancer and appendix cancer are very different. The appendix cancer don't follow the APC pathway. That's why Dr. Shen's looking at using taxanes, which I think is really exciting. I'm really hoping that pans out, that we have more options to, you know, to treat appendix cancer with other chemotherapies. So I'm not aware of the prognostic implications of BRAF and appendix cancer at this time yet. So I agree. I just don't think we've answered that question, but it certainly doesn't jump out to me. Like I don't think there's data to say that it's behaving the same as in colon cancer. I don't think we've shown that at all.
No, and sometimes it's just nice to have something to target, right? It may not have the same prognostic implications, but it may still allow you to take a drug from another group and know that it'll target your tumor. So that could be a good option.
The next question is about kind of about timing of when to switch to clinical trials. So this is somebody who's been on chemotherapy, keeping the tumor at bay for 12 months. Surgery is not an option. When do you advise somebody to think about clinical trials?
You know, in general, I think whenever we're reaching for second line, you know, if the first surgery wasn't as effective as we wanted, we weren't able to achieve it, and we're wondering if the other systemic therapy is going to be effective, I think it's always good to start searching early, just because every clinical trial has its own unique criteria that you can fit in. And sometimes if you've seen too many therapies, you know, it has to be second line. So I think it's always a good idea to keep it, if we're on second line therapy, to keeping it in mind, what's out there now and what might be out there soon. But in general, I think, you know, I think of clinical trials as always a good idea for everyone to think about, but particularly when we're kind of running out of the standard therapies that most of us would offer as first or second line.
Yeah, I would agree with that too. So I think if something's working and the person's tolerating it, the side effects aren't overwhelming, I think keep using that until there's signs that it's not working anymore. And then again, looking at more conventional options until those are exhausted. But if you're, having that sense that that's going to happen, obviously at some point, then like Dr. Ward said, the earlier you start looking into what clinical trial options might be available, the better you'll be prepared and know what the eligibility criteria are for that. So I wouldn't without knowing all the details of that particular case, I wouldn't necessarily say now is the time, but but to be thinking about it at some point. Mm-hmm. So, and then this is a question about Signatera. Then the question is, what treatments have you seen for patients who have positive Signatera to be the most effective? I guess that's a question about maybe describing the utility, like what is Signatera used for, and how we're using it at this point. So.
Yeah, I think right now I'm not sure we can feel confident that if you have a positive Signatera, that should mean you should go on chemo or surgery. I think what it says is that we should probably be, looking for maybe recurrent disease. So whether that's having a higher suspicion or maybe doing a scan a little bit earlier if we don't see anything, or if we have a high suspicion in the belly. I think some people are doing diagnostic laparoscopies earlier. I think, depending on the disease, that may or may not make sense for that person because they're still an invasive operation. And I think the true answer is it ultimately depends on what kind of disease you have. So for colon cancer, I think might make more sense to think about systemic therapy but for appendix, where it's still going to depend on, what type of appendix tumor you have. So I think generally, I think there's no good data to say 100% what should be done next, but it's a good signal to you and your physician to start looking at things closely.
Mm-hmm. Yeah, I agree. It's a relatively new tool, and we're still trying to figure out how best to apply it. One of the challenges of treating with chemotherapy, if you can't actually, with just Signatera, if it's just Signatera positive, is that you don't have any way to know if it's responding other than, I guess, if the Signatera becomes negative, but you still don't really know where the disease is that you're treating. So that is a question that's yet to be answered about, how do we act on the Signatera only if that's the only thing that's positive. So for those of you who don't know, Signatera is the cell-free DNA. So literally finding DNA from the tumor in the bloodstream signals that there's probably a recurrence somewhere. And then the last question that we have in the chat is, it's actually for you, Dr. Ward. For low-grade disease, what are your thoughts on systemic chemotherapy? Is that an option?
I mean, I think Lori is a great example that, when low-grade disease doesn't act like low-grade disease, we have to go back to the drawing board. And if we can't do surgery for one reason or another, then and we think it's acting like a higher grade disease, then, I think it is good to consider systemic therapy. And I think we, like we talked about earlier, we rely on the chemotherapy we have often give it to colon, and that's not a perfect science, right? We know appendix and colon are different. But, together with the medical oncologist, if that's what we need to give it a try, we have seen some people have, lack of progression on systemic therapy. In general, I think CT scans limit our ability to see really good response, even because it's just hard to tell what's just free floating mucin and what's the cells making the mucin. But I would say in general, I think it's the right thing to do when you have limited other options. And then obviously we also explore clinical trials when that's appropriate.
Yeah. Great. Well, I think that's all the questions that were in the chat. Does anybody have any closing comments that they want to make? Well, I want to thank everybody who joined our regional symposium. I really want to thank the ACPMP Research Foundation for just all the incredible work that you've done. I think somebody earlier in the symposium maybe didn't put it in this way, but it really feels like we're creating a critical mass of clinicians, scientists and, the ACPMP Research Foundation really coming together. And and I do agree. I do think we're also seeing an increased incidence of this. That was one of the questions that came up in the chat earlier. What do we think is driving that? We really don't know. I do think it's real. I think, Deborah, I think the ACPMP Research Foundation is successfully completing one of its missions to increase awareness and educate people. And I hope, hope the group that was here today and the people that have been on, the participants, will feel empowered to advocate for themselves, reach out to the specialists if they're in a place where they don't have expert pathologists, where they don't have high-tech surgeons, that they get the referrals that they need, that they push for that their pathology is being reviewed appropriately, because that's critical, and that they're getting getting to the resources that they really need for this rare and challenging disease to treat. So I congratulate you again. I'm so grateful to be a part of your team and this mission and these symposiums. So I just want to say thank you again to Lori and John. I know this wasn't easy. I really appreciate them sharing their story and for letting me be a part of their story as well. So
thank you.
Thank you.
And I just want to thank all of you, and thank you again, Lori and John, for telling your story, and Dr. Lambert and Ward and Leonard for coming and giving your time. Everything you do is just so appreciated, and we're constantly at ACPMP. I field the phone calls. We get several a week with people that are in desperate need of a real specialist because they're being treated by people who really are not the right people. And I'm just so grateful that I have you all to continue to funnel patients to, and you take such good care of them. So thank you. And thanks for all you do, Dr. Lambert. I know I pester you with questions all the time, and you're always just so incredibly responsive and helpful. And thanks for the good lead on exhibiting at the American College of Surgeons Clinical Congress. That was tremendous. That's a tremendous part of us increasing awareness, and you've always got such great guidance. So thank you, and thank you all. We're stronger together.
Yes, we are. Absolutely. Yep. All right.